Welcome everyone to Dental XP today. My name is Richard Aiken. I'm a practicing oral and maxillofacial surgeon coming to you from Baton Rouge, Louisiana. I'm really excited to be here. I think Dental XP is a wonderful collaborative learning site where we all get to share our experiences. And today we're going to be talking about the trabecular metal implant, specifically how it's fitting into my practice. We're also going to talk about how I've implemented provisionals into a surgical practice. And I'm going to share my experiences through two cases and a video. And we'll also talk about the specific properties of trabecular metal and some nuances of this implant and the placement of this implant. This first slide kind of goes through basically how we're going to go through the lecture, which is going to be talking about the implant as it's implemented in a immediate provisionalization case, and the nuances of placement. And then we're going to talk somewhat in depth about provisionals and how I feel provisionals can be performed predictably and some of the techniques that I use. So the new implant surface technology obviously is going to be a big part of this webinar today. We're going to also be talking about my feelings about minimally invasive surgery and how basically over the past 12 months I've noticed significant differences in the procedures, the outcomes of the procedures I've performed, patient comfort, etc., with minimally invasive flapless procedures when indicated. And like I said, we're going to talk about provisionalization. You can see a provisional on the screen, also a couple of diagrams that I've made, and we'll come back to most of these images later. Let's start off with our first case. And this is a acutely fractured tooth number 7. And as you can see, we have a really nice thick gingival biotype. These are the ones that we really love to see in our practice. Makes it very easy to provide a predictable immediate provisional solution. And here's the occlusal view. Great tissue contours. There's really the only problem here when I'm looking at this site is if there's decay around the prior margins of where this tooth fractured, and that can make it difficult for removal occasionally. And of course, we always worry about ankylosis with these root canal treated teeth. Here's the periapical image. Just notice the interproximal bone. I'm always taking note of that to determine if we expect our papilla to come back. Of course, this patient doesn't have a great interproximal peak, but very thick tissue, so we could expect to get good papilla fill. And most importantly, from a provisionalization standpoint, I like to have good apical bone volume. You can see we have great apical bone at this site, no true periapical lesion. And when I get started here with this procedure, what you didn't see me do is to use a number 15C blade to kind of help reflect and initially incise the periodontal ligament fibers. And I'll also use a periotome. In this case, I noted that there was some great solid dentin to hold on, basically to engage, and for the forceps to hold on to. And these forceps are really my go-to. I have some other types of forceps that I use, but these are ones that I've customized, and I will sharpen. I'll just use a tapered Fisher burr with loops under magnification, and make sure they're nice and sharp. That way they can slide down without impinging on the buccal plate, and I have very good grip with these. And using a rotational movement, we can get the tooth out with minimally disturbing the gingival anatomy in the area and any of the bone. This is what I like to see when I take out a tooth in the aesthetic zone, when I'm planning an immediate temporary and immediate implant placement. And here's a root. When I take out these roots, I like to take a look at them, and I like to see where the periodontal ligament was. I like to measure the root. It gives me an idea of depth of implant placement and what to expect from the depth of the socket. And of course, we can compare these to the adjacent roots and as to how deep we could go before the nasal floor. And in this case, I'm using a perio burr. This is a burr, just a football Fisher burr that I use to deepithelialize the socket, kind of freshen it up, and to make sure that any granulation tissue has been removed from the area. And here's the site after. I'll look in, I'll inspect, I'll make sure the buccal plate is intact. We have a buccal plate that's intact about 3.5 to 4 millimeters below the free gingival margin. And this is something that I always want to make note of, because this can change how I approach the case, not necessarily if I do or don't provisionalize or place an implant, but how I manage the reconstruction of the buccal plate. And I'll go through the drilling sequences. We'll do that again in the video, but you'll see here the final drill in place. I like this view because it shows you the ideal location of the last drill, or while you're drilling, you want to be looking at this, and you want to make sure that these drills are, fairly palatally positioned. You want to make sure that you're, not necessarily engaging where the root apex was, but that your trajectory is just right for screw retention. And I'll harp on that because all of my provisionals are made screw retained. I feel that not only does implant placement to allow for screw retention make for an ideal final result, but it also forces me to have a nice buccal gap, which I can fill with bone to make sure that I have a nice buffer between the implant and the buccal. So you can see this final drill in place. I like it near the cingulum of the adjacent teeth. You can see here. And we have a nice buccal gap, thick tissue contours. This is about 2.5 millimeters. And here's the gingiva is fully intact throughout the socket. And the trabecular metal implant. Here is a 4.1 by 13 millimeter trabecular metal implant. Of course, this implant is made by Zimmer, and it has some very interesting properties, which we'll go into now. When we talk about new implant surfaces, new implant designs, there are new words that we can use when applied to these new technologies. One is osseoincorporation. You can think about bone as opposed to excuse me, bone on growth. We're talking about bone ingrowth. And this trabeculation that you see in the implant here is where we get bone incorporation and bone ingrowth. These are important terms to think about because traditionally in implant dentistry we talk about bone on growth. And even then we talk about bone to implant contact, and we know that's not perfect. This technology, though, allows for true incorporation of bone into these trabecular patterns and these trabecular cells. So let's just look at briefly the evolution of dental implants over time. We've got a macrostructural situation where we had bone ingrowth into some of these older Corvin implants, blade implants. And then we went into more we can call microstructural implants that were developed with HA coatings, with titanium sprays, titanium plasma spray, beaded implants. All of these had pros and cons from a surface standpoint. Some of them had good or marginal success. And when we talk about the application of trabecular metal, we're really talking about something different, though. We're talking about a consistent and a novel application of this material to the implant body, utilizing what we know about titanium already and the Zimmer TSV implant, which this was applied to. We are enhancing that implant. And this is some other views of the implant and how the trabecular metal is applied, and we'll talk about that in an upcoming slide. First, let's talk about tantalum. We need to understand that trabecular metal is not titanium. Trabecular metal is tantalum. So when we get to this, when we look at this periodic table, number 22 on the periodic table is titanium. We're all familiar with titanium and its applications in implant dentistry. But let's look at number 73. And tantalum is number 73 in the periodic table, and it has applications currently in orthopedics, and specifically spine, hip, shoulder, joint surgery. And it's probably has about a 10-year or so record and research background in orthopedic literature. And remember that, and make note that tantalum is a very biocompatible and corrosion-resistant metal. In fact, Brandon-Mark's early studies of osseointegration were conducted with this material. And we have some studies that had been done in canine mandibles that show bone ingrowth into this trabeculation of tantalum, this application of tantalum in about 2 weeks. So we know that the body likes tantalum as much as it likes titanium. And you can see on this slide a number of studies to support that. Now let's go back to the case, and here's the implant. Now in my specific case, I feel strongly about the use of biologic modifiers. So I will use biologic modifiers with this implant into the trabecular surface. In this case, I'm using PRGF, and I've used PRGF in my practice for over 6 months. Before that, I was using PRP, but this has allowed me to use biologic modifiers in a wider variety of patients, and I love the results with it. In fact, I try to use it in almost all implant cases, and I've found that applying this PRGF to the surface of the tantalum is a nice way to deliver it to the site. And here it is. This is fraction 3. For those of you that are familiar with PRGF, fraction 3 is the most concentrated portion of the 3 fractions of PRGF. And this is what I usually will add my bone to. And in this case, I'm using a xenograft bone. And there is the PRGF in this case not only aids in the delivery of growth factors, but is nice as a graft retainer and a graft delivery medium. And I place the bone into the socket, and I will kind of compact the bone against the buccal wall, then engage and place the implant. I'll engage the implant at the near the palatal area. Obviously, I try to keep the bone graft out of the osteotomy site, because then we can have problems with full seating of the implant. And after the implant's placed, typically what I'll do is I'll do an Ostel reading. Ostel's been a big part of my practice as well. It helps me with one more determination of implant stability. We have our handpiece, we have how we prepare the site, and we have the torque drivers, which give us that tactile sensitivity. Ostel also helps me with tracking implant healing and provides me a stable baseline. And if I think there's a problem over time, we can take out the temporary and provide an Ostel reading, which gives us, it's a great device and takes out the guesswork. In this case, the ISQ value was 65, which for those of you that are unfamiliar with the Ostel, 62 and above is typically characteristic of a very stable implant. Of course, this does not tell you about osseointegration. It tells you about, it's just measuring implant stability. And at this point, I will usually go ahead and measure the depth of implant placement and its relation to the buccal plate and the gingival tissues. Now we're going to get into some of the provisionalization, And I want you to see, these are the products that I use. My assistant gets these together for me, and she'll check the tooth shade, the size, and in this case I'm using a denture tooth. Denture teeth work very, very well for this, and they have just a wonderful color, and they hold up well during a 3 to 4 month provisional period. Occasionally we can load these implants early, but they provide a great solution and give us enough time for implant healing. You can also see this is the peak abutment. This is a roughened. I have roughened the surface. My assistant will roughen the surface as well, and we will treat this with binding agent. Also, we have the short provisional abutment screw and the long abutment screw. Now I'm showing you the placement of the provisional abutment. In this case, I'm using a binding agent, and from 3M, and this is being placed into the site using the long abutment screw, which will stick up high and allow me to make sure that the provisional shell is in a good position for screw retention. And in this case, I'll deliver the provisional shell, or the denture tooth in this case, with a micro brush. I'm using some flowable composite and binding agent, and it allows me to manipulate this a little bit easier because these can tend to get away from you a little bit. And when I seat the provisional, the denture tooth, hollowed out denture tooth, what I'm doing is, you can see in this area, I am actually allowing for facial contour and support of the tissue. So I'm actually kind of putting pressure, facial pressure, against this gingival margin. And you can see I've tried this in a number of times to make sure that I've got enough of the denture tooth cut away here so that I can allow for screw retention without having the incisal edge kicked too far buccal. Now at this point, I'll go ahead and use flowable along the back of this, and it will all come out as one piece. And you can see the provisional lifting out, the provisional abutment with the denture tooth binded into place. Here's a provisional prior to final finishing. I will rough it out at this point. I'll make sure that all the voids are filled in. I will start on the contours, and this will go in the mouth. I'll check the bite. I'll then make sure that the pillows are supported, the facial marginal tissue supported enough and not compressed, but just supported. And this is the beginning of the finalization of the provisional. Let's just talk with a few slides on talk about the provisional and what I think are the important parts from a surgical perspective on provisionals. This is a provisional that I made and for a patient, and I'm going to talk to you about from this is the ideal view to look at provisionals from. I feel, of course, we need to have the aesthetics right. We want to have the incisal edge in the right position. And some of those things are what I would consider a common sense approach to provisionals. But some of these other factors may not be really forefront in our mind when we provisionalize, especially when it comes to surgeons providing this. And we talk about, and when I look at my provisionals closely, I look at these areas. Initially, I want the first part that I look at on provisional is after I have captured the provisional abutment and adhered that to the denture tooth. I like to look at to make sure that I have the composite flush with the margin of the provisional abutment. From a surgical perspective, plastic abutments serve to have a lot of advantages. I have used titanium in the past. I find them to be very unforgiving, and it makes it very easy for me to provide a provisional solution on a plastic abutment. It gives me a latitude that I find I don't have with titanium. That's my personal preference. I feel that Titanium offers advantages such as being radio opaque and allows you to fully verify seating even radiographically. Oftentimes when provisionals are seated, when you're using a plastic provisional abutment, it's radio opaque, so you can't tell. But I would say that I feel very confident about full seating because sometimes I can even watch that provisional seat. I feel its seat. Plus, I know that provisional is fully seated because when I pick it up, there's nothing impeding that the provisional have been seated properly. What I mean is that since I seat it first and then capture the provisional at that point, there's nothing that will impede its reseating, especially if I make sure that where the incisal edge position is. And maybe I'll see that a little bit better when we go over the video. Next, I like this highly polished subgingivally. This is very important because the subgingival margins are where we're getting that junctional epithelium and the epithelial healing taking place. We don't want any irritant down there. We know that there aren't any perfect provisional materials in the subgingival area, but we know that having these areas smooth can be very helpful from a healing standpoint. Next, as we work around the provisional, I really want to have the access hole very smooth. Patients can complain, if there's an irregularity in the access hole. And in my provisionals, I will fill the access hole with retraction cord and ferment. Next, I do like to utilize custom staining. I find that denture teeth do a great job of giving you nice translucency and having transition zones from enamel to a translucent enamel to a nice transition like a tooth would have down to the cervical region. But I do like to custom stain. I don't typically custom stain interproximally where this arrow is, but this is usually on the facial and after the provisional has been finalized. And lastly, but most important, is the gingival support. The gingival support is really this area, and this is the area where I am most concerned about from a facial gingival margin standpoint. I am not concerned in this area because this is an area that I want under contoured, and this will allow for more tissue volume, allow for maybe some graft material to, whether that be connective tissue grafting or even some of your bone graft particles, which will be incorporated into this coagulum and can allow us to have a better gingival margin thickness and stability, I feel. But when you look here, this area, maybe 1 or 2 millimeters here, is all you need to support your facial gingival margin, and that's what's very important. And when we talk about placing this provisional, let's go back to our case, and you can see in the site I've placed a bit of PRGF. This is fraction 2. I'll use this in the sulcus to aid in socket sealing, and I'll then place the provisional into that area. And you can see the provisional will then reestablish the facial gingival margin, and I'm hopeful that it will add a little bit of compression into the interproximal areas and help with papilla fill. If we look occlusally, you can see what we have. We have the provisional abutment. Here we have our short abutment screw, temporary abutment screw, our composite, and the denture tooth. And these are all one unit, delivered as one unit. I am usually not too concerned about the lingual or palatal aspects of the provisional. I only want it to serve as a socket seal, and the palatal aspect of it needs to be contoured and smooth, but is not where most of the work goes into. Most of the work goes into making sure that we have nice facial anatomy, gingival support, and polish. When we take a final radiograph of this, You can notice the trabeculation of this implant, trabecular pattern of the implant. You can see the apical threads, the crestal threads, and this is the provisional in place. In this case, the implant was placed approximately 3.5 millimeters subgingival, approximately at the level of the buccal plate. And here we are at the completion of the procedure. And this has been stained. I'm using a provisional staining or composite staining kit called Trabecular, and that allows me to put a nice finish on this, and it gives us some real nice gingival support as well as color to the provisional. It blends in very nicely, and it gives us, the most importantly, this support to the facial gingiva, and of course most important to the patient is a nice cosmetic outcome. Here we are at a 2-week follow-up. You can see there's been very little changes in the mucosa and the gingival margin, and typically this procedure, there is very little to no pain. In fact, this patient came in just recently and we were talking about his procedure. I have some 6-week photos from him I'll show you in a moment, but he reported zero pain. I find that when you're doing minimally invasive surgery, when you're using biologic modifiers, and when you're provisionalizing, the patients have zero pain. In fact, he didn't even take any non-steroidal anti-inflammatories afterwards. It was my recommendation to take them, but he did not. Let's look at this study briefly. In this paper, Dr. Hahn talked about in the JPRD in 2010 the importance of the critical and subcritical contours of the provisional, and this being a very critical area here. Now these areas are also critical, and these areas along the paddle, like I said, non-critical, but we need to provide for that soft tissue support like I had discussed, and we need to make sure that we have either a flat or a concave subgingival surface of the provisional. As you go into a situation like this, where we have a convex subgingival surface, you will begin to see marginal gingival creep apically. It happens. Conversely, if you make sure that you allow for this concavity, you can see facial marginal gingiva become more coronally positioned. And I've heard lecturers on Dental XP talk about this. I've seen it in my own practice where we remove temporaries. That's what's great about them. I can remove this, since it's screw retained very easily, place it on an implant analog, add composite where I want to. Occasionally I'll mark it in the mouth with a pencil and add or subtract where I want it. This makes it very easy. Again, with screw retained provisionals, we avoid the need for any cement in the area. I avoid cements as much in every case. In fact, I always screw retain because I do not want cements down by bone graft materials and in areas where I can't see. So remember, make sure that you're under contoured here and avoid that red zone there. Another slide on provisionals, and then we'll move on. Here's a provisional that I made for a patient, and I just found this view to be very beneficial when I talk to doctors about provisionals. And let's look at some of the fine points of this photograph. Here you can see where the provisional, once it's seated, will support the buccal gingiva. Another important aspect of a provisional is that it acts as a graft retainer. It supports the papillas, and Obviously, that's important for lots of reasons, especially in the aesthetic zone. And very important, which I had just touched on, which is allows for retrievability. In premolar cases, there's a number of different techniques I'll use for premolars. There's something called pro-temp crowns, which are basically a partially cured composite resin type crown, which is very easy to work with from a surgical perspective, and I will use those oftentimes in the premolar areas. Also, denture teeth work very well. I'll just take off the working cusp and utilize the nice facial anatomy of denture teeth. Also, I will use, it seems like a lot of times we're removing the mesiodistally fractured first premolar, and we can use the facial, the buccal cusp and the buccal anatomy of these premolars and use that almost as a veneer and make provisionals that way. And again, with provisionals, when we look at these on radiographically, we can see that just if you leave these in, there's been a lot of talk of one abutment one time or getting as close to that as we can. I try not to remove provisionals for 6 weeks. I like them to stay in while the bone matures, for us to have a nice junctional epithelium present, and for the tissues to mature. Then I'll remove as necessary and ostel and maybe load early. I often find that if we talk about early loading, I find that with high insertion torque implant placement, we could get early restorations in place if we wanted to, but quite often patients are fine with waiting a little bit longer if we needed to because they've got a nice provisional. It buys us time. It gives us something that's sculpting tissues while the healing process is going on, so we don't have to push it. But oftentimes, we will get these loaded early or finalized early, and that's another advantage to the patient. So if you look at this periapical, you could see, or this bite wing radiograph, you could see the interproximal bone. I see this very often. When I'll provisionalize and leave the provisional in place, I see very little bone dieback, if any, over time. So we'll go back to the case, and this was a patient yesterday, and he came in and I removed his provisional, and this has been 6 weeks, and you can see there's always a little bit of wear on the surface of the provisional. Occasionally I will have to restain the provisional or do some minor adjustments. Typically what I do, I take out the provisional, I clean it well with alcohol, Q-tips, etc. I will then polish again outside of the mouth. I will then use Palaceal or Seal and Shine or some type of unfilled resin to fill in any voids. And then when I replace this, I will use a chlorhexidine gel. You can see the radiograph that was taken yesterday. This is again the 6-week follow-up. We have very good interproximal bone, and you can see the full anatomy of the implant in this figure. The ostel reading was 64 at this point, and here's the provisional being replaced. You can see some of the chlorhexidine gel. Dr. Sonia Lizet in Vancouver, when I had spent some time with her, she was using this, and she had this formulated from a local compounding pharmacy, and I've done the same, and I really like it in these areas. Sometimes when we have any kind of provisional components may not have the best seal, so this is a nice way to seal, to kind of add an antimicrobial agent to the sulcus. And here it is seated finally, and this patient is ready for final crown delivery and impressions and delivery, and he's thrilled. He's ready to get the final on. He doesn't want to have to be worried about temporary breakage. I always tell patients that they need to be concerned about that, especially during the first few weeks after the implant's placed. Most importantly, the second 2 weeks, I tell them, is the most important time to be very careful, because as we know, with implants, the first 2 weeks, things are fairly solid. We have about 2 weeks where we have a significant drop in implant stability, maybe not clinically significant, but I tell patients to be careful. And then most important, if I'm going to immediately provisionalize a patient, I tell them that they need to be aware of this, that this could break. But most importantly, they could damage the implant. And during the preoperative interview, I've become very astute at finding patients that this may not be a great solution for, but I will say that over 95% of the time, I am using provisionals and I am flipper free. Now, when you look at this slide, it's very interesting to look at how trabecular metal mimics trabecular bone, and it mimics it in in another way, not just in an ultra-structural way. Let's just magnify this and just look at the nanotechnology. We have we have a macro structure, which are these trabecular cells, but we also have this nano texture to the tantalum. And when we look at trabecular metal and how it's made, I was able to go up to Parsippany, New Jersey to see how this was made, and it was fascinating. It was somewhat over my head, but I found it very interesting how they developed this vapor deposition process. They use vitreous carbon, and it's a vitreous carbon substrate. The tantalum is then superheated, and then it is applied over many, many hours in a vapor deposition process to the surface of the vitreous carbon. And this now has made tantalum a viable implantable material. As I've looked into tantalum and researched on my own, and I was wondering why tantalum hadn't been available for so long, because titanium's been around a long time as an implantable material. The problem with tantalum is that it has a very, very high melting point, and that has made it very difficult to make lots of applications for it. And let's just look at this H&E slide of the trabecular metal implant in orthopedics. And what you can see is tantalum here, and you can see bone growth into the cells of the tantalum. And this will go through and through the trabeculations. And again, as I had said, a really important factor for me in providing this solution for patients is that the 10 years or more that it's been in orthopedics gives me a lot of comfort, because there are great studies that are showing its biocompatibility in the body, and it makes sense to apply this to a titanium substrate in a way. And when you look at the implant, that's basically how it's applied. When we look, we have a titanium top, we have a titanium core. The tantalum sleeve is then fixated to the titanium core, and then we have titanium again at the bottom. So you can see titanium's almost the other substrate for tantalum. It's very interesting also to look at how cancellous bone, we look at its modulus of elasticity. Cancellous bone is about here, and trabecular metal is here. This is very important because when we look at titanium, we know that titanium is a unforgiving, from an occlusal standpoint, it's very unforgiving. Trabecular metal has better, more physiologic properties when applied in the mouth and when applied to dentistry and occlusion. And you can see also it compared to cortical bone and to chromium cobalt. So let's look at another case, and this is an immediate mandibular molar case. There's a implant in place in position number 31, which has been there about 10 years. They've been placed by another doctor, and number 30 is now failing. And we can see the periapical radiograph. There was a fracture noted here by an endodontist friend of mine, and there is also a slight buccal gingival abscess. I will just as a little background, I do provide immediate implants in the molar regions. I have also, and you'll see my technique for immediate placement here in a moment, but I also really like the idea of customized healing abutments in the molar regions. Just as we would provide provisionals in the anterior to allow for anatomic healing, I like anatomic healing in the posterior. And I don't think we talk about this a lot, but in my opinion, allowing for, rather than placing a uncontoured healing abutment, I like being able to utilize a customized provisional abutment. And I'll talk to you briefly about how I go about doing that. So we'll apply our principles of minimally invasive flapless surgery. And in this case, I always want to use a probe and radiographs and cone beam CTs if needed to determine as much information as I can prior to going in. If I tell a patient that there's going to be a 95% chance they're going to either have a provisional and/or in a molar region, an immediate implant, they like that. They come to me for that. My referrals expect that of me. They know that there are tremendous advantages to immediate implant placement. And when we really look in the literature, we see that there are even studies out there that have shown great results with immediate provisionalization of molars. A lot of this is a testament to high insertion torque and great implant design, and also towards, and to me, predictability lies in minimally invasive procedures when we can, and getting the information ahead of time. Sometimes we can't provide that. If we've got serious buccal plate involvement and we need to reconstruct that, that's maybe times where we need to step back. I have found, though, even in those cases with minimally invasive surgery and tucking membranes and things like that, we can still provide the solution. Now, you can see here we have the flapless removal of tooth number 30. I'll usually remove the crown. I like it when I can kind of tease the crown off. In this case, I had to cut it, and then I sectioned the roots. And you can see I'm using a periotome. Again, I'm a firm believer in customization of my instruments. I feel like all of us have different ways that we practice. We have a one instrument, but excuse me, the instrument, the way that we use them may differ, and customization of those instruments is important to me. So I'll customize the periotome in this case. You can see the beginning of the implant procedure and the positioning cylinder here. The positioning cylinder is in place in the furcation. The implant needs to be in the center, and I don't place implants in the mesial or distal. I place implants immediately in the center of the tooth. I want this to be optimal restoration position. The way my philosophy for implant dentistry is, I want to place the implant as if I'm going to restore it. And this is where I'd want it, and this is, if I was a restorative dentist, where I would insist upon it being. And I like it along the central groove. I will often, once I place the positioning cylinder, I will take the bite block out. I'll have the patient close. I'll make sure that this is going to be occluding with the ideal place along the maxillary lingual cusp of the maxillary molar. If a patient has first molar occlusion, you can see, you'll know if this is in the right position. Also, I take these check radiographs. I find them very valuable when I'm doing any implant procedure, but especially immediate molars. The other thing that's tricky about immediate molars that I found, though, is curve of Spee and curve of Wilson. And when we talk about that, sometimes we're tempted to place implants upright, but we need to realize that implants need to follow those two principles from occlusal principles, and how as far as how the implant should be angulated. We want the implant angle we want the occlusal forces along the long axis of the implant, and we remember those things when we're doing immediates. And I guess my advice would be, if it's difficult, there are cases that are very difficult to place immediates in. The ones that are the most difficult for me is when we have very little space between the inferior alveolar nerve and the apex of the tooth that I had just removed, and also if the interproximal bone has been destroyed by periradicular infection. Now let's move on, and here's the implant. And this is a 6 millimeter by 11.5 trabecular metal implant. And this is, I think I have mentioned, this is made by Zimmer. And this is the fraction 3 of the PRGF and I'm applying this to the implant. And in this case, I actually also wrapped the implant in the PRGF and used the implant again as a delivery medium, as a delivery unit for the PRGF and the particulate bone. In this case, I was using a particulate allograft, and you can see the implant in place on the left. You can see the delivery mount removed on the right, and below the Ostel reading. The Ostel reading was 71, and we know that this signifies very significant implant stability. Again, just look at where the implant is positioned. This is, in my opinion, an ideal position for a molar implant. What's done at this point is I will compact the bone circumferentially around the implant. I won't go supracrestal with the bone. I'll go to the crestal depth and then kind of slope it down to the level of the implant. And when I am fabricating the provisional, what I would consider the customized provisional abutment, you can see I like it to support the facial marginal bone. I want it to occlude the socket and use the same principles that I use in immediate provisionalization for these customization techniques in molar sites. You can see on the left side we have the radiographs, we have the panorex and the periapical. You can see the implant in place, and in the middle photograph you can see I've actually tucked in some PRGF fraction 2 along the buccal to also act as a graft retainer. And here is the occlusal view. On the right, the occlusal view, I've altered the colors a little bit so that you can see where the gingiva is and where it should be. Look distal and look at number 31 and look what's happened on the buccal contours of that implant. That is what we see all the time. And when we either provisionalize molars or I'll provide this solution, we will we increase at least the space for graft material, and we also reduce the changes in the buccal gingival anatomy. I've seen these when I have provisionalized molars. I see very little changes along the buccal for whatever reason. Maybe there's graft incorporation into the gingiva. Maybe there is, it allows for the support of the gingiva during the healing phase, so there's less scar contracture. Whatever it may be, this allows for a much more anatomic final impression and what I would consider a better long-term anatomy in the area. Trabecular metal. A few other things about it. It's a very osteoconductive material. It has this interesting 3D architecture. Understand that the porosity is about 80%. That's very porous material. And the cells are in a dodecahedron pattern, which is a 12-sided pattern. And you can think about it almost like a soccer ball. And that is how these trabeculations support one another in a 12-sided environment of cells. And these cells are 540 microns. Remember that, and I've learned that 300 microns is the minimum that can support bone growth with vascular channels, and in the case of trabecular metal, rather than 300 microns, we're talking about 540 micron cell size. These are, I hope that I've been able to show you the application, at least how I've started to apply trabecular metal in my practice. We'll go over a video right now where I will show you the placement of a immediate provisional. This is site number 8, and this video will demonstrate my provisionalization technique. It'll show you the trabecular metal implant and how and where it's placed. I may pause the video because I want to talk to you about a few of the nuances of maybe the drilling sequence and the implant feels different when it goes in. So there are some like any new implants and new surfaces and new patterns of implant surfaces. There are nuances, and there is somewhat of a learning curve here. So let's get started on this case. And here's the immediate provisional, like I had said, of number 8. Patient had marginal failure around this crown. Here is the initial presentation and the marginal gingiva, as well as the smile. Low smile line is always nice. We have I always get a lot of information from probing. And once the patient's anesthetized, we can probe much better than we can at the preoperative appointment. And if there's any question about buccal plate thickness, I will get a cone beam. The buccal plate was in a very favorable position. And here I am, I'm using these crown graspers and I'll take off the crown and the post. I'm now using a 15 blade, and I will use this almost to begin the elevation of the tooth. It acts almost as a very thin periotome. Now I'm using those same forceps, which are somewhat customized and very sharp at the tips. It'll grasp the tooth, and in a rotational fashion, I will then go ahead and remove. And I want minimal to no disturbance of the buccal plate or the facial gingival anatomy. In this case, I'll use a curette and make sure any periodontal ligament fibers have been removed. And again, I will verify the position of the buccal plate, especially in reference to the adjacent teeth. And we have a buccal plate at a 3 millimeter level on the buccal, and it is fully intact. Now I'm using the ultra-pulsed CO2 laser, and I love this laser, and especially for this. It just tends to shrink down the tissue. It de-epithelializes the gingival margin. It removes that inflammatory component, and it really aids in the healing, I feel. Now I'm using a pilot burr here. This is one from Salvin, and this, I'm beginning my osteotomy. I'm not going towards the apex. I'm staying palatal, and I'm drilling at about 500 RPM here. I'll place this and use this as my positioning cylinder and take a check radiograph. You can see where the anatomy is and where we are, and we're different. We're in a different position than the anatomy of the socket and the tooth. We're more mesial, and you can see here I do like to use slow drilling and capture some of the bone if we can. And occasionally I will not use irrigation on 1 or 2 drills while I'm feeling the bone consistency and hardness. And here it is. Here's the occlusal view, and you can see the position of this step drill along the palate. And I'm going pretty slow here, and I'm feeling the bone. I'm making sure not to over prep this area. Remember that we're only going to be engaging the apical threads of the trabecular metal implant, and that goes for any of our provisional procedures, right? We're usually only stabilizing these implants at the apex. In this case, I stepped back and made sure that I had enough depth so as the implant's inserted, I do not bottom out. Here's the implant. I'm also using a 4-1 by 13 millimeter trabecular metal implant, and here I am placing. I'll start off with a placement handpiece torque of 25, and then I'll kind of go up from there. I will seat so as to not impinge the placement and seating of the implant. I will remove the delivery mount and then go directly to the implant in this case. I'll verify insertion torque. It was approximately 35, maybe slightly greater than 35 Newton centimeter. And here's the implant in place. Ostel reading is done today as a reference. And SmartPeg has gone in, and here's the wand to determine the ISQ value, which in this case was 61. And here is the provisional my assistant has prepared for me. I will try it in, make sure that there's no impingement interproximally, and that I can provide for a good buccal gingival support. Placement of the provisional abutment, which has been prepared. Here you can see this is the Zimmer Peak abutment, and I'll make sure that this fits passively over the provisional abutment and the long abutment screw. And I want to make sure it seats fully, that I've got enough taken off at the incisal edge. And here is the view. It's basically has wings on it, and I'll cut it out, and I'll just show you, since we didn't talk about this earlier, I'll show you this briefly. The wings are here, and in this case you can cut this off completely and use it almost as a veneer. I find if the wings are in place, it kind of begins the circle of the flowable composite and will help index this a little bit better if you can do it. Now, here I am with I'll use the micro brush. I've got it bonded to the provisional. This is basically a handle. It allows me to move this around a little bit less crudely than with your fingertips, but sometimes you need to use your fingers to hold this into position while you're getting that initial tack cure. And you can see I can put some facial pressure at the gingival margin to support it. And I'm just manipulating it here. I'm just making sure that I'm going to be able to manipulate this adequately, and the bond is going to stay in place on the facial aspect of the denture tooth. So now I'm using the AdPer bonding agent. This is the 3M bonding agent I'm using, and I'll treat both, then light cure. Now I'm using flowable resin, and this flowable resin will then be I'll seat the crown, and I will tack cure. And most of the time, this comes out as one piece. If you don't get a bond or you have bond contamination, you got to do it over and you got to take out what you have, because even if it indexes and you don't have a bond, though, you just really have to start from scratch and take all that composite that you added off. What I'm doing here is I just want you to see that during this provisional period, while I'm fabricating the provisional, I'm using PRGF on a cotton tip applicator. I'll use PRGF because the site can get somewhat desiccated, and I like to just keep delivering growth factors as much as I can. In fact, in one of the drilling sequences you had seen earlier, I'm using fraction 3, the liquid phase of fraction 3, and irrigating with that. And that, again, helps me constantly deliver growth factors to the area. Now what you're seeing is the provisional almost complete, taking it off of the implant analog, which I was using as a handle, and I'm going to place it. And what I'm looking for here is we're going to check the bite. We're going to make sure that the gingival margin supported, the pillows are in good position, and that we have interproximal contact. All the things you would want in an optimal implant restoration. And I'm checking the occlusion here, and this is checking him in CO, and I'll of course check him in protrusive contact. Now I'll take the provisional off, place the cover screw, and start placing bone. In this case, like I had said, we're using a particulate allograft. We're using a particulate xenograft in this case. And we're compressing. This takes time. And of course, I've cut out a lot of the video here for you, but this is where I think you want to fill in all the voids. I like a firm compression of this material. This is fraction 3 with the xenograft, and I will compress. I'll use different types and different sizes of amalgam pluggers, basically, and it takes time, and you really want to have thin and maybe some thicker ones available at thin and thick. See, this is the thin-tipped amalgam plugger, and allows you to get the bone really compressed and fully down into the area around the implant. I just don't feel that there's any advantage to having voids here, so this takes some time. Now, once we've got most of the bone placed, I will then use a much thinner tip here, and this is where I'll kind of sculpt the bone in the sulcus. I will make sure the bone is fully compressed where it needs to be, adjacent to the adjacent bone, and then slope down to the implant. Now I'm using fraction 2 on the buccal. I will seat the provisional by trying to keep this fraction 2 in place, and it usually works very well. Then I will tuck it in, as you'll see in a moment. Here's the provisional finalized. And when it's placed, the PRGF is kind of trapped on the buccal. And then I will use my thin graft packer and I will tuck this in the buccal. And this again delivers more growth factors and acts as a graft sealer and helps secure the graft into position. I don't like any dead space, and I think that's one of the reasons why patients have such good results with this as well. There's no dead space for swelling or inflammatory mediators. Now you can see I'm using the Trabecular, and this is just this stain, and it's a resin stain, and I will go ahead and apply the stain and kind of make sure it's in a uniform fashion. I don't use any air spray in this. I don't like air in here because I don't really want anything going down into the sulcus or going into areas I can't see. And here we are, pretty much at completion. We will cure this, and then I will place the retraction cord on the lingual and firm it to seal the access hole. Here's the firmament going in. We'll smooth this off. I'll use alcohol-soaked cotton tip applicators, Explorer, etc. to make sure that this is smooth and not caught interproximally. We'll do our final cure here, and occasionally I'll go back and just do some slight refinements. This I find very enjoyable. And providing this solution for this patient before he left, that's the final view of the provisional you just saw. Here he is at a 3-week follow-up. 3-week follow-up. Good retention of anatomy. Excellent gingival positioning and contours, no pain. These are all the things that I enjoy with provisionalization. I find that provisionals, they allow me from a surgical perspective to provide what I miss most about dentistry, which is what patients really want. And what they want is a nice tooth to leave with. And they don't want flippers, and they don't like pain. And I think that what you've seen today, as we've gone through what trabecular metal is, we've gone through some of my practice philosophy, which is to provide the best solution, minimal pain, the best, and a really nice provisional solution. Because when the patient goes back to my referral doctor, that reflects on them as well. It also, when that provisional is just right, it helps that doctor with a blueprint for the final implant crown and abutment contours, etc. Provisionals also allow for a very easy final impression, meaning the impression coping goes right in and everything is really in a anatomically perfect position. So I'd really like to thank you all for joining me for this webinar. I want to thank Zimmer for helping us put on this webinar with Dental XP. I want to express my appreciation to Dental XP for having such a great website. It's helped me since I've been a member. I've learned so many things and has given me exposure to general dentistry topics that I never would have known about, and really helped me in my own growth in my own practice. And I hope that you can all use this webinar to grow yourselves. And thank you very much.